And because the reality is we all could be living to 120 with a high quality of life. That can be the reality currently for everybody. It's very clear that like the science is there, the knowledge is there, the tools are there. You just have to do it.
Right. Welcome to Health Hacker Life, Dr. Vass.
Thank you.
I'm excited.
Thanks for having me.
It's going to be a fun session today. So we're up in Nederland, Colorado. This is my first official in-person interview in this new studio up in Ned. Dr. Vass is one of my personal physicians that I've worked with a bit here in Boulder to help me hack the issues in my tissues, as I like to say. And so today we'll jam a little bit about some of the work you've done to help me progress in my areas. We're talking about one of those right before we hit record. But I'm excited to unpack your brain and your background and your expertise and your work in the world. You know, I'm really excited about what you and your practice, the clinic, Rocky Mountain Regenerative Medicine, right?
Yeah.
Is doing in Boulder. So if you want to start by talking a little bit about what RMRM is about, kind of what you guys do as a practice, let's start it from there.
Yeah, sure. So I guess should probably start with I'm a traditional medical doctor, trained, went med school at Cornell, general surgery at University of Colorado, and then emergency medicine at Denver Health. So, and then I worked in that world, in the emergency medicine world for, a decade plus, and got really dissatisfied with not just how medicine is administered in this country, but also how the therapeutics and the doctor-patient interaction really gets tainted by the system. And I think that's a problem that everybody feels on some level. And so I was, dissatisfied professionally. And the flip side was that I was also a patient in the system. And so I was, using the system as a patient for, medical issues, have like familial high cholesterol was the big one at the time. And the solutions that I was getting in the system were not giving me the outcomes that I really wanted. And where the rubber met the road there was, in my work in the hospital setting, I started seeing myself in my patients. And I started, seeing people who were having, problems with plaque buildup, cardiovascular disease, strokes, et cetera. And on the progression to that. And I remember when I started saying, I was like, well, that's me in 10 years, probably. Mm-hmm. And then, you see somebody else, you'd be like, that's me in 7. That's me probably in 3. And, at some point I was like, I really don't want that. Right. I want to go somewhere else.
Right.
And yet, when I see my friends who are specialists in these areas, the lipid specialists, the cardiologists, they're giving me all the same answers that all these other people are getting. And I'm on the road that they're on, and I want to go somewhere else. And so I started looking really for solutions for my own issues. And out of that, that's really how the practice was born. And so, Koshal is my partner. He was with me. He had a lot of the same sort of professional dissatisfaction issues. And we were both ready to just say, like the system, and it's hard because the system can be great, right? Like if you're having a stroke, if you're having a heart attack, if you're septic, if you got hit by a car, like there's amazing things that happen in the system.
For acute issues.
Yes. If you've got a problem now, and the bigger the problem you have now, the better the system is at taking care of it. But if you don't have an acute problem now, and if you have some kind of chronic, low-level health issue or medical issue, even on a very minor level, the system really does a very poor job of dealing with that in a way that prevents those bigger issues
Right.
that the system is good at taking care of. And so our practice was really born out of that sort of personal journey for a better satisfaction with, my work, with my career, and better outcomes for myself as a patient. And that's really sort of the framework that we use for the practice, which is we don't want to have anything interfere with the doctor-patient relationship. We want to be able to spend as much time as we need with people.
Right.
We don't want to be, on a hamster wheel running to see people, one after the other. And, I don't know from your end, but it's like if we have 5 appointments in a day, that's a lot. Usually because we want to stack 20, 30 minutes at least between appointments because, if you run over, if you as a client have an issue that demands more time, like I want to have the time to spend with you to figure that out.
Some buffer, which is completely the opposite in the regular system of Western medicine, right?
Yeah. And so, really we removed ourselves from the system, which freed us up to sort of create an environment that we felt good about being in, that we felt good about interacting with people in, and in that environment offer the types of therapies that lead people to different outcomes.
Right. That really make a difference.
That really make a difference. Yeah. And not just, and so we're talking sort of like in the preventative care, primary care space. So we do a lot of that. Mm-hmm. But what we also do, which is, I think, really why we're unique, is that we do a lot of the interventional because of our skills from the traditional setting and all the time we spent. We have a set of skills that most primary care doctors, functional medicine, naturopaths, that they don't have. Mm. And so, we are able to perform, minor surgery in our office. We do a lot of invasive, highly technical injection therapies under digital fluoroscopic guidance, ultrasound guidance. So, we do stem cells. I know, I don't know if we've mentioned that yet, PRP. Right. So we do a lot of these interventional techniques. Yep. But where we're different from a lot of quote unquote stem cell clinics is a lot of stem cell clinics, they're purely focused on musculoskeletal they're sports medicine practices. And these therapies are great in those settings. And their applications are actually much, much broader and greater because these interventional biologic therapies don't just heal musculoskeletal tissue. They can heal all tissue. So you can heal lung, you can heal liver, you can heal spleen, you can heal gut, you can heal brain injury, you can heal spinal cord injury. And, a lot of stem cell clinics don't, stray from the straight, rotator cuff, knee cartilage. That's all they do. And we do a lot of that, but we also work in this space where a lot of clinics don't go, which is using these biologic therapies to heal other organ systems and other tissues.
I didn't realize that.
Yeah. So maybe I don't know if that was too much, but that's sort of how maybe the long description of our practice.
I love it. That's great. What really stood out to me was what you said at the beginning and how you were professionally and personally as a patient kind of disgusted by what you were experiencing. And it sounds, I can only imagine what it's like to work in emergency medicine, right? That's the acute of the acute.
Right.
Talk about high levels of stress. And what you said about wanting to create something that you almost wanted to experience. You wanted to create an environment of care for patients that was the type of care you wanted to receive personally, right? Yeah. You and your partner that you mentioned. Yeah,
absolutely.
That's huge because for me as an individual focused on optimizing my own health, I have more and more respect for the health professionals that practice what they preach and what they teach and are on the path themselves as the health hackers, as I like to say, right? Like on the journey of optimizing their own health and well-being, and that's because that gives me more confidence that my doctor knows
absolutely
what they're talking about.
It's interesting because, particularly when we, like at this point, we are now the experts in the, so I just returned from like one of the big stem cell conferences where I was lecturing, presenting, data that we had published.
Amazing. Where was this?
It's in Vegas.
Yeah.
So this happened earlier in the summer, but when I was first learning about these therapies, I was a novice. I didn't, I had to learn this somewhere. And so I had to go outside the system to learn it. But some of the people who are sort of like, purported as experts in the industry, they're not taking care of themselves. And there's always part of me that's like, if you're up there preaching health, like shouldn't you be healthy? And I think there's better role models now, than a decade ago. But absolutely. Yeah. I'm interested in this stuff, not just because it's what I do, but it's because it's what I'm interested in knowing about and applying for myself.
Right.
I want to live a long, healthy, happy life, and be high functioning the whole time. And because the reality is, we all could be living to 120 with a high quality of life.
Right.
That should be, I don't want to say should be the reality for everybody, but that can be the reality currently for everybody. It's very clear that like the science is there, the knowledge is there, the tools are there. You just have to do it.
Right. Takes guidance, support, and commitment long term, right? And that so you living to 120 under the umbrella of longevity, right?
Right.
Obviously, lots of areas of health optimization play a role with longevity, and everything you're doing at your practice plays a role with longevity. One of the first things you mentioned was your own personal health challenge, familial cholesterol, which I too have that in my family. I don't have the, I did some genetic hacking to understand like the ApoE gene and see how well I handle saturated fat, and I'm the so-so, I'm the one in the middle.
Yeah.
But I'm curious to hear a little bit about your journey with heart health and cholesterol.
Yeah.
I had a scare last year, I may have mentioned to you, or a couple years ago, where I did a Cleveland Heart Lab panel looking at LP little a.
They probably do lipoproteins, oxidized cholesterol.
Yep, exactly.
VLDLs
and a few, and they were high, and some of them were really high, and I was somewhat worried. I talked to a doc at the time, a cardiologist that wrote a book on like a functional approach to healing. And he's like, oh, well, the most important thing you need to look at is your CAC.
Okay.
And I know there's so much that plays into it, but he's like, that's how you know if like you truly have. So I want to keep going down the rabbit hole of heart health hacking, because I understand like it's such a killer in our world.
Yeah.
Right. And so, I've done the supplements, the niacin, the spermidine.
Yeah.
And so I'd love to hear from you, like what were some of your challenges that you went through there, and what were some of the hacks and approaches you took, both on the testing side and then the intervention side that made a big difference?
Yeah. And so for me, I was diagnosed, I went to an elementary school in LA. So I grew up in New York, but we spent 3 years in LA, and they had a school screening program where they'd come in, do blood pressure, they'd do like a little finger stick, and they check, from the tiny little bit of blood, like your blood sugar and then a total cholesterol. And so through that, they found like my cholesterol was like 400. And, I was a healthy, skinny, active kid. And so I became sort of like a poster child for this program, because they were not just what was important for not just me, but from me being identified, they basically identified all the males, because then they started testing, so I went to the doctor and I got tested. They were like, was it a mistake or is it real? It's like, oh, it's real.
You got more testing to confirm it was real.
Yeah. So, the school program, they had a nurse, met with my parents, discussed the results, said, you need to get into your doctor. They retested, confirmed, did the breakdown, not just the total. And then from there, my father, my mother, my sister, and then even my cousin, it turns out like all the males on the father's side, on the Greek side of my family, we all had cholesterol through the roof.
Wow.
Total cholesterol is in the four plus range.
Wow.
And so, I started early, first was diet, and then there weren't really any pharmaceutical or drug options that people were willing to start a middle schooler on. At that time, it was the 80s, and so, anyway, to kind of fast forward a bit, the protocol that I was put on, that I stayed on, which was frustrating me, was, first it was pre-statin. There were drugs that I used to take that never really controlled my cholesterol. Once the first statin came out, I was old enough. I was put on a statin. We'd have to ramp the statin dose way up. It would never actually totally control my cholesterol. And every time a new statin came out, they'd say, oh, well, first it was Mevacor. Well, Zocor is going to be better than Mevacor. And then after Zocor, it was atorvastatin, and then it was Lipitor, and then after Lipitor, it was so there's this laundry list of new statin after new statin. And the reality was the statins never controlled my cholesterol, ever. They might get them to the upper 200 range total, and we'd ramp up the dose, and then my LFTs would start. Like, I never had any muscle symptoms that I was aware of.
As a result of taking
the drug.
Right.
And so the reality was my cholesterol was never controlled, ever.
Right.
And then as I kind of got older, into my 30s, now I'm a professional, I'm a physician. I'm like, man, I'm going to go see, now they're lipid specialists. It's not just a general cardiologist, but they just had the same playbook. It was like statin, then you start taking a baby aspirin, then, well, I was always active and athletic. So because then next they want to put you on a blood pressure medicine. And first it's, it might be a beta blocker, or it might be a calcium channel blocker, or then it's an ACE inhibitor. And so this was the path I was talking about. It's like, okay, statin, aspirin, beta blocker, ACE inhibitor. And the only reason they're doing those things is because there are studies that demonstrate mortality risk in people who have cardiovascular disease. So meaning if you have known cardiovascular disease, a statin gives you 3% mortality risk benefit. And, and every other drug, actually aspirin is better than that. It gets you a little bit more than 3%, gets you about 4% mortality risk benefit. And so that's why those are sort of the cornerstones of traditional cardiovascular disease treatment in this country. And with that, my cholesterol was never controlled. And so I'm on these drugs because they're supposed to be what's right for me, that I know from the literature and that my friends who are specialists are telling me. My cholesterol's never been controlled. And I'm seeing myself marching towards stents or bypass surgery, which my uncle had. And so, so I'm familiar with this pathway.
Right.
And this is where I'm like, there's got to be something else. To cut to the chase, now what I know is that there's testing that should be done. Didn't exist when I was a kid, but it exists now, where you actually look and see where that cholesterol is coming from in your body. Is it an overproduction of cholesterol, or is it overabsorption of cholesterol? And the story I had been told my whole life was that, your Mediterranean background, you overproduce cholesterol. That's what a statin treats, is it lowers the body's production level of cholesterol. And everybody just sort of pigeonholed me in this sort of category of like, familial high cholesterol means you're overproducer. Overproduction, the drug is a statin. The reality is I'm not an overproducer. In fact, I'm underproducer. and I'm a significant overabsorber.
Interesting.
So there are receptors in your GI tract that pull the cholesterol out of, the intestine from the food that you eat.
Mm-hmm.
And it turns out that when you're an overabsorber, it doesn't matter what you eat. And this was true, like from what I experienced, no matter what I ate, no matter how strict I was with my diet, my cholesterol was never controlled, ever. And you put me on a drug that lowers your body's production of cholesterol, has nothing to do with the absorption.
Right.
And so they had me on the wrong drugs.
Mm-hmm.
And these
so
are.
Did you go off those eventually then?
Yeah. I mean, well, so my point is that's step one. The knee-jerk reaction is high cholesterol, exercise, diet. Do that for 3-6 months. We recheck, it's still high. Here's a statin.
Their menu of medications.
This is what is currently being done.
Right.
And so the reality is cardiovascular disease, cholesterol levels themselves play less of a role than most traditional doctors sort of. If you weigh what they think in their mind is the cause of plaque formation,
mm-hmm.
in most doctors' minds, it's cholesterol. Right. But
right.
the reality is it's not actually cholesterol. It's oxidized cholesterol, and it's the lipoprotein profile.
Right.
But guess what? Most insurance won't cover testing oxidized cholesterol and lipoprotein profiles for most people.
Right. So it's not generally accepted through.
So they can't even. So what propagates the mistreatment is the lack of the ability to get the proper tests.
Mm.
So you have generations of doctors who don't even know that there are other tests that they should be ordering because most payers won't pay for it. Therefore, it's outside of they're totally in the box, right? They're so limited by what the system enables them to do that the system actually hinders the advancement of the medical education.
Right.
So you can go learn about lipo little a, lipo A, lipo B,
right.
oxidized cholesterol levels, CRP levels, and what that means for, cardiovascular disease and how that and then even doing the next level of treatment, or the next level of diagnostics, which is, okay, where is this cholesterol coming from? And then I would even argue now there's, the coronary angiogram scanning that's available currently, has been FDA approved for 2 years now, that insurance still won't cover, that gives you better images of the heart vessels than angiogram. And all it requires is a simple CAT scan. So the reality is that medicine currently is stuck in a paradigm from the 1980s. And let's face it, like our world does not move. We're in a world where you can click a button and Amazon will deliver some, you could get it delivered that afternoon.
No other aspects of our world have stopped innovating.
And information, with the internet, social media, the interest in health and longevity. And, most patients I would argue that probably most patients who are listening to this are better educated than their doctors now, even just listening to what I just said about cardiovascular disease and how to diagnose it and treat it. Right. And so, the short answer to your question is appropriate testing, which is step one.
Right.
If you have high cholesterol, is it oxidized? What are your inflammation levels?
Right.
And I'm skipping over diet because I'm assuming, this is something like most people listening to this are probably, well aware of the dietary options. And I would argue there's no one perfect diet for everyone.
Right.
But there are general guidelines that you can use and modify to your purposes. And there are a lot of really great resources on that. I'm happy we can go into diet more too. But that's step one.
Right.
Because, if it's really just, you have a little bit too much inflammation, that can usually be mitigated by appropriately managing leaky gut and gut inflammation and with supplements that help scavenge free radicals. And usually those two simple things alone will help squash most of the inflammation in your body that's oxidizing your cholesterol.
While pulling out like the inflammatory foods.
Yes,
which
exactly. Sugars, high
crappy
processed,
oils.
exactly.
Yeah.
And so these are simple things, and they're not expensive. You go ask most doctors. I mean, I would argue that traditional medicine in their dietary recommendations are probably a decade or two behind what is currently known about diet.
Mm-hmm. Yeah. Not a lot of education, and
it's not taught. They're
Did
so
you have
busy.
nutrition education?
We did 5 days.
Yeah.
In medical school, and to frame that, we did biochemistry. So the biochemistry I did in medical school was so I took a year of biochemistry in college. We did 75% of what we did in a year's course in college in 2 weeks in medical school. And that's just the pace. So, and it's one of those, like, that was the first thing we did. I was like, holy crap, we just did almost a full year of college material in 2 weeks. So to frame that, it's like that, those first 2 years of med school, they suck for a reason. And so, it's easy to say we spent a week on nutrition. You could argue like that would be like probably a semester course in college.
Right.
So it's something.
It's a lot.
It's something
packed into those weeks. Yeah.
And it's totally inadequate because, like, if you look at the American Heart Association, like if you go now and look at what they're recommending, you would probably be like, well, this is information from, 10, 20 years ago.
Right. Or it's clearly connected that they've got big food in their pockets to some degree.
Well, and so I have friends who sit, I have cardiologist friends who sit, on some of those panels that help. And so I've gone to them. I'm like, listen, man, and this 7 years ago, it was even worse than it is today. So, like a decade ago, 7 years ago, I'd, go to a friend and say like, man, what's up with your dietary recommendations? Because if you follow the AHA diet recommendations, guess what you have? You have your perfect stent candidate at 55 to 60. So to me, it really looks like you're just putting money in your own pocket. So explain this to me. And the answers that I got were actually, I felt legitimate. And what I was told was, they're like, hey, listen, we know that this is totally inadequate, because not just the diet, it's their exercise recommendations. Mm-hmm. And I think their exercise recommendation was like 30 minutes, 3 times a week. It could be walking. Right. Nothing about heart rate, nothing about zones, nothing, zip. And I was like, you're making people obese, and you're giving people atherosclerotic cardiovascular disease with these recommendations.
Right.
Why aren't you actually making legitimate recommendations? And they said, the reason is because we're not worried about all your clients in Boulder. We're worried about Joe Sixpack in Middle America, who, if we actually told them what they had to do, they would say, there's no way, like, that's totally unobtainable. And so what we're trying to do is trying to edge them toward the ideal diet. And I'm like, well, how long what's the strategic plan there? Is it going to take you a decade to get them?
How are we going to implement?
Yeah. What's the rollout plan? And the reality is there's no rollout plan, but they're just scared. They're like, if we really tell people, then nobody's going to try. Yeah. And so, like, people on this podcast are not the people they're trying to recommend diets to, but then, what I argue is then it delegitimizes your whole organization, because it looks like you're creating business for yourself.
Right.
So anyway, and so I don't know if we completed the path, but yeah, appropriate testing.
Yes.
Appropriate lifestyle recommendations. The testing, you're going to have to pay out of pocket for it.
Right.
And so like the Clearly test or this coronary angiogram.
So let's talk about, you mentioned the testing is step one. And what I often will say to people is, because usually HDL seen as the good guy, LDL seen as the bad guy, right? So like high LDL on its own is not a risk of heart disease.
Yeah.
Would you agree? Is that what
Yeah, I think in broad strokes,
Right.
yeah, that's a reasonable way to think about it.
And then if you go deeper to really understand the particle sizes, the oxidation, the LP little a,
Yep.
everything underneath the deeper advanced
Yeah.
lipid, like ion fractionization, right, of
Yep.
the lipids. So there's the biochemistry, biochemical blood testing. You can get advanced to get these biomarkers we're talking about. But then so let's talk about some of the imaging.
Yeah.
Because that's CAC. What does that stand for again?
It's a coronary. I'm not sure. What I call it is it's a coronary angiogram.
Okay.
Yeah.
Got it.
And it's a CAT scan. It's a 15-minute test, 20-minute test max.
Okay.
You go in, if you've never been in a CAT scanner, it's like you lay on a table. There's like a big donut that, there's a thing running around you.
Yeah. So that's what I did.
That uses X-ray.
Yep.
And you're probably talking about calcium scoring.
Got it. Where they give you like a 0
Yeah,
if you're
0
clear.
to 80 or whatever.
So I was a 0.
Yeah.
On that.
And so here's what I would say.
Is there any value in that test?
It's not that there's no value. It's just that imaging is obsolete
compared to what you're
so imagine doing that. That's the first part of coronary angiography. Then, so they do one set of images without contrast. Then you need an IV for the type of imaging I'm talking about. And they give you a dye. And what the dye does is it just lights up the inside of the blood vessel. And so now you have an image of the blood vessel and then an image of the blood flowing through the blood vessel that you can layer on top of each other. And you can now actually see the lumen, which is like if the blood vessel is a hose, the blood is flowing through the inside part that either has air or water in it. Like the water is the blood, but the hose itself, the wall of the hose, that's the blood vessel.
Right.
And it's what's going on. The plaque buildup happens in the wall.
In the wall of the blood vessel.
In the wall of the hose.
Right.
And the human eye cannot see when you overlay those images. It just looks like grayish, scaled images. So even the most expert radiologist can't see plaque. But what's so amazing about Clearly is you run it through an AI protocol where that they've based off of angiogram data, and the computer can see the density difference and can identify plaque that the human eye cannot see. And the important thing about this is that calcified plaque, which is what a calcium score CT does, is the hard plaque. That's plaque that's been there for a long time. It's scarred, so it's calcified. And that's why you can see it on a regular, just plain CT image. That's not the dangerous plaque. The dangerous plaque is the soft plaque before it's been calcified and hardened. That's the plaque that's at risk for rupturing. And not just the soft plaque, but more specifically necrotic plaque. So as plaque builds up in the wall of the vessel, it's basically plaque is fat. As fat gets deposited into the wall of that blood vessel, it slowly grows over time. And it can grow to a point where it actually grows so big that it narrows the flow of blood through that hose. And that in and of itself can lead to heart attacks because you just slowly, gradually, close off and squeeze off the arterial flow. But that's not actually the really dangerous plaque. The reason is because that tends to happen so slowly that the body, particularly if you're active, will build collaterals around. So your body, as this stable plaque is slowly growing over years and years, if your body senses that it needs more blood flow, it will grow new blood vessels around those hard plaques. So the calcified plaque is usually not the dangerous plaque. The plaque that's dangerous is the soft plaque before it starts narrowing the vessel. It gets necrotic, means it literally gets rotten inside in the center. And when it gets rotten, it's at risk for rupturing or literally like blowing up. When that soft plaque, which is not very thick, it doesn't narrow the lumen or the flow of blood through that vessel much until it suddenly ruptures and clots. And that's where you go from, blood flow that's mostly normal, maybe 20% narrowed, 10% narrowed, very minimally narrowed. But that 10% narrowing ruptures, a clot forms, and suddenly the clot blocks the whole artery. That's your heart attack.
Got it.
So the calcium score CT shows you the plaque you're least interested in.
The hardened. Right. So you mentioned Clearly is the name?
So this is Clearly is the name of the company that has this patented software. And really the CAT scan technology you can get anywhere. The CAT scan itself the technology is old. What's new is taking those images, layering them on top of each other, and running it through their AI database. And what you get out on the other end is a clear picture of all of the plaque in your coronary vessels.
Got it.
And the few cardiologists that I know of who use this agree that you get a better assessment of the plaque buildup in your heart vessels than you do during an invasive coronary angiogram. And that's due to the like an angiogram, all they're doing is they're squirting that same dye into the heart vessels and then taking x-ray pictures. And so they're looking at the x-ray pictures for where is the narrowing, but they're only doing that when people are actively having heart attacks, right? Because they're looking for the severe narrowing so that they can put a stent in there. They're literally like roto-rooting the clog. They're like, where's the clog? And let's open it up. Clearly, years and years before you end up in that scenario can not only show you if you have any hard plaque, it shows you the soft plaque, and it'll show you if any of that plaque is necrotic.
Got it. Sounds like I need to do a Clearly test, right?
If you have,
I want it. No,
it's one of those things that I would say anybody 50 and over in our practice, we recommend. It's not something you do every year,
right?
But it's like a colonoscopy. Every 5 to 10 years, most people should get a Clearly study,
right?
And the reason is not just to know, what the plaque burden is, but it's because there are actually therapies that you can use to not just stop plaque formation, but to resorb the plaque.
So let's talk about some of those. Like if I got my Clearly results and I had some things to work on, maybe I had some of the bad soft plaque, the necrotic rotten that's floating in there. What are some of the top strategies that you take from there? I mean, I know we can talk diet, but I'm curious.
Yeah, beyond that. So beyond diet and exercise, there's the traditional pharmaceutical playbook where like aspirin, statin, ACE inhibitor do play a role. Like if you had soft necrotic plaque, yes, those have benefits for people.
Got it. And they also have downsides too.
Of course. Right, so every drug has a plus and a minus.
Right.
And this is where it's like, so say you're somebody like me, or say, you're me a few years, say you're 45, you have some high cholesterol, and this is the typical scenario is like, my doctor has me on 20 milligrams of Lipitor or Crestor or something. And they've done none of this testing. Now, if you have, your cholesterol's a little high and you don't have a lot of inflammation and there's no oxidized cholesterol and your lipoprotein profiles are good and your Clearly is clean,
you shouldn't be on that.
Why would you start a drug that, do you see what I'm saying?
Right.
Now, if your cholesterol's high and your lipoprotein profile is not great and you have a little bit of plaque on your Clearly, like a totally different aggressiveness level in how I would medically treat that.
Right.
Like, yes, aspirin, yes, probably statin, yes, maybe Zetia, yes. So there, do you know what I mean?
What was that last one?
Zetia or Izatembi. It's the drug. So if you have an absorption problem, that's one of the drugs that you can use, meaning you absorb cholesterol, too much cholesterol, or overabsorbed cholesterol. That's the drug that will block those receptors. That will also drive down, so and then I would argue, the lipoprotein for cardiovascular disease, little a and big A are important, but B is more important.
ApoB.
ApoB, yeah. And so driving ApoB, I mean, the closer you can get it to zero, frankly, the less likely you will have, cardiovascular disease. And most normals, this also gets into the lab where it's done, what their normal level is, and what's optimum.
Right.
Because their reference range usually is based off a bell curve of the population.
Right.
Not what optimal actually is.
Yes.
And so having somebody who understands the difference, because a lot of doctors, so we'll do lab tests on people, and then people will go, they'll just run it by, they'll go to their regular doctor and be like, hey, I had this lab work done. What do you think? They're just, getting a second opinion,
you're in range.
What I'll tell you is even most cardiologists, we're talking maybe 5 to 10% of cardiologists at this point. And I'm just basing that off of the people that I see who've been into cardiology and lipid specialists, the testing they have done. 90 to 95% of the people who've gone that route haven't had any of this testing done.
Personally, for themselves.
Yeah.
Wow.
Who have these problems. So anyway, so that, does that answer, so the proper testing, the proper imaging, you can tailor an appropriate therapy regimen.
Right.
And then we just talked about the traditional therapies, that there are also alternative therapies.
Right.
So,
like for me, so I just turned 35.
Yeah.
And I'm wanting to keep working on optimizing like the key areas that present the higher risks, whether now or down the road.
Yeah.
I would opt to, if possible, avoid some of the general specific medications.
Yeah.
I used to be like keto, high fat, moderate protein, low carb. I mean, I'm not keto now. I eat plenty of carbs. I enjoy my saturated fats.
Yeah, sure.
I'm wondering so for what are some of the other alternative hacks?
Therapies.
Yeah, for whether it's supplements or other therapies. Yeah.
Yeah. So supplements that, so here's how I kind of stage, how I think about treatments in my mind. So, lifestyle, diet. And so diet, it can vary, but a good baseline is sort of the Walter Longo Mediterranean diet sort of definition is sort of a good baseline to start from. It's to summarize it. It's vegetable heavy, complex, carbohydrates, mostly complex, whole grains, protein is, and meats are part of the diet, but calorically make up maybe 30%. So protein. Yeah. So when you think about that, like there's a lot of calories in protein. So that the protein portions are smaller relative to, the vegetable, like how many calories you're getting through a vegetable source.
Right.
And you, I guess you're allowed in my mind, like, 70-30, 80-20 is sort of the rule I use in terms of like, how rigidly do you stick to that versus, when can you go eat some junk or stuff that, that's not ideal.
Right.
So I usually tell people, if you are good, if you are strict with your dietary recommendations on weekdays, on weekends, it's not like just eat junk all the time.
Right. Yeah.
But that frees you up to go out to dinner and not worry about what you order.
Right.
And order what you want and get to enjoy it, because for me, any diet, it needs to be sustainable.
Right.
It needs to be something that you can enjoy eating on a regular, everyday basis. And because otherwise, what's the point? Like, right? Like if we're all just, super strict with our diet and you can never enjoy it, like what's the point of that? And so, I guess in broad strokes, that's sort of, Walter Longo Mediterranean diet, 80-20 sort of application.
Sure. Yeah.
And then what's important about Longo is that, he incorporates and so broadly speaking on time restricting your eating. So like what a lot of people call intermittent fasting. It's great. It's great for ketosis. It's great to mitigate inflammation, and you can go too long when you time. So what I call time restricted eating is what most people call intermittent fasting. And because really all you're doing, fast is a term I tend to use for multi-day severe caloric limitation or water only or no food like fasting.
Like a 24 or 48.
Usually
fast.
72 hour, like so to a 72-hour window with 800 calories or 600 calories or less.
Oh, per day. Got
and
it.
so that's just sort of like the term. This is semantics, so a lot of people call intermittent fasting, I call like you're time restricting your eating.
Yeah, your food windows.
Food windows.
Yeah.
And so there is good data that going beyond a 12-hour window, can drive in some people, because some people like a warrior or like, going 16 or 20 hours works great.
Right.
But in many
metabolisms are different.
genetics
are different.
Exactly.
Yeah.
And so in many people, going beyond a 12-hour window, it starts being really stressful on their body. They start secreting cortisol, adrenaline, sugar, so you can get into a spot where like you could be time restricting your eating too much.
Yep.
And so, so I usually, as a general rule, I say like 12 hours is typically enough time restriction to get the GI rest, to get a little bit of ketosis, and, going longer than that can be detrimental depending. Right. On the individual.
Right.
And then, so time restricting to 12 hours around, a little more, a little less, depending on individuality. And then implementing, at least 2 times a year, a more stringent, true fast, which is where you go.
No calorie fast, right?
Ultimately, ideally, yes.
Right.
Or, like 200 calorie or less.
Right. Kind of like the fasting mimicking diet.
Fasting mimicking diet. Right. And so like for me, that's what I consider ideal, which is if you time restrict your eating 12 hours, you adhere to a Longo definition of a Mediterranean diet 80% of the time, and then twice a year, you're doing a 3 to a 4 or 5 day fast. That's sort of like broad strokes. If everybody in the country just started doing that, we would see significant like changes in health outcomes.
Right.
And so, and then, there's plenty of room to specifically tailor that. And it's not that, everybody needs to eat that way.
Right.
But does that answer the question?
Yeah. You bet. I played around with 48-hour fasts. I've made it almost to 3 days, but I think I need some accountability on that. There's lots of great science and data on those longer fasts for longevity benefits, right?
Yeah.
And like clearing out overreactive muscle cells, immune cells. And
it's the senescent. So it's that triggering, the clearing of the senescent cells. It's that autophagy.
Right.
Now there are ways around that, right? So I think fasting is sort of, it's nature's way, it's nature's right? Like and so I'll bring in the stem cell analogy. Stem cells work so well because it's how we heal naturally. Like they're the cells that we have. That's how we heal damaged tissue. They do it better. Like we know a lot about them now, more than we did when I started using them for sure. But we still only understand them incompletely. They're smarter than we are, right? Like they know how to heal better than we understand how they heal.
Right.
And so they're such a great therapy, particularly when you compare them to synthetic standard of care therapies. They're so much better. It's nature's, like depending on what you believe, a lot of people, it's like God's way or it's Mother Nature's way. It's whatever it is, it's the natural way that we heal. And of course it's going to do it better than a mimicked synthetic version. Right. Like they have an intelligence unto themselves. The fasting you get with autophagy is, in my view, like it's there's more going on there than we understand. We can mimic some of the portions of that we understand. So we can, and that's where I'm saying, like, you can hack some of that with therapies, like using methylene blue, FOXO4-DRI, NAD. Like there's a whole playbook of how you can trigger autophagy, rapamycin, metformin. But that's just what we understand of autophagy. And I guarantee you there's more than that that's happening. And so that's why I'm personally a fan of fasting, because there's more going on than we understand, and it's nature's way of doing it. It's going to be better than whatever we can try to mimic.
Right.
But there are people like, certain diabetics, like it's not really safe for them to fast.
Of course. Yeah.
And there's some people, like my wife is a good example. She's a very healthy person, but she just doesn't do well. She's like, it doesn't work for her.
And generally women, it's harder and less optimal for them to explore fasting.
So I would argue women in general, unfortunately, for some reasons, their systems are more complicated. They're more sophisticated. And so that, they have a hormonal cycle that's way more complicated than like men's. We don't have a cycle, right? Like ours is simple. Just that hormonal cycle in and of itself that they have to deal with cyclically on a regular basis adds a layer of complexity that is just totally beyond what it is in males.
Totally.
And so, yes, there's a particular time, like if you're going to fast, it's better to do it in the earlier parts of your menstrual cycle.
For a woman, yeah.
Yeah, when their testosterone levels are higher and the progesterone levels are lower, the demands, their body is better able to cope with the stress that because fast, I mean, it's a stress. You know it if anybody who's tried it, it's a stress on your body, and it's best to do that at a time when you're capable of handling it.
Right.
And so the answer is, it's not that women shouldn't fast, but you're 100% correct. It's more complicated. Right.
More challenging. Yeah. Well, you started to get into the stem cells, and I would love to transition to that topic right now. It's been something that I've been seeing you for, I don't know, a little over a year.
Yeah.
You guys just moved to the new location. I've been receiving Shockwave.
Yeah.
I want to talk a little bit about that therapy, which its intention is to generate stem cell production for self-healing. And so the use of actual stem cells as well, injected and in other ways, I want to go down that rabbit hole. Because I know there's the stem cell clinics that are just in it for the money, or that are doing it the wrong way. And there's all different ways, all different sources and types of stem cells. So can you give a little bit of a broad stroke overview of the different types of stem cells and kind of where we are at now?
Absolutely.
As a state or as a nation, and then eventually get into your approach.
Yeah, sure. So, saying stem cell therapy is a little bit like saying surgery. Like, I'm going to go have surgery, right? It's like, okay, are you gonna,
what type?
Are they gonna do a skin biopsy because that's a surgery? Are they gonna do a liposuction because that's surgery? Are they gonna open up your abdomen and take out some colon because that's a surgery? You know what I mean? Like, it's so biologic therapies and biologic cell therapies is, in my opinion, it will be a whole sort of specialty, quote unquote, in and of itself. Regenerative medicine at some point will probably be a specific traditional track where you go to med school and then you go do a regenerative medicine, residency or fellowship to learn sort of the playbook of different cell therapies.
That'd be amazing.
That still doesn't exist.
Right.
But the reality is that there are many, many different types of cell therapies. PRP is the most common type of cell therapy. It's not a stem cell therapy, not what I would call a stem cell therapy. There are a lot of clinics that call it stem cell therapy, but PRP is really you're drawing blood and isolating the platelets. Platelets have within them, we think of them as clotting, they initiate the clotting cascade, but they also contain within them many proteins and growth factors that functionally, once they form the clot, where do you get bleeding? You get bleeding where you have injury, right? So you injure tissue, you get bleeding. Then you get clot formation. Platelets show up, they form the clot. They then degranulate or release all these proteins and growth factors into the area of injury to stimulate inflammation and healing response.
Mm-hmm.
And those proteins and the growth factors are self-explanatory. Like, you have damaged tissue, you want tissue growth, you release growth factors. A lot of the proteins that are contained within platelets draw in local stem cells from the surrounding tissue to help facilitate the healing. So a lot of clinics, the reason why I'm mentioning, I don't consider PRP a stem cell therapy, but some clinics call PRP a stem cell therapy, which can be misunderstanding or confusing for patients.
Right.
Because we've seen a lot of patients who, they're like, oh, I've already had stem cell therapy. And then when you dig into it with them, you're like, well, what did they do? How did they do it? And they explain it to you. And you're like, but you didn't really have, what I would call stem cell therapy, you had a PRP injection.
Right.
Which activates stem cells locally where that injection was done, but they're not injecting
Actual stem cells
in the stuff that, it's not like they draw the blood and they isolate stem cells from that and then inject them.
Right.
So PRP is a different kind of therapy, but it's a cell therapy. Then we get into, there's actually some other things like alpha-2 macroglobulin, and platelet-rich fibrin. So there's a kind of a whole sort of set of therapies that are cell therapies that come usually are derived from a blood draw, and are not what I would consider true stem cell therapy. So even though it's not included, I included in there just so people, if they're not familiar, PRP is a platelet injection.
Right.
When we get into the actual sort of stem cell category, what most people use in this country are bone marrow. They're harvesting bone marrow. So they do a procedure where they go in, usually to a bone in the pelvis or the hip, and they draw out some bone marrow, and then that bone marrow aspirate, or what's drawn out of the bone, is then processed to concentrate the stem cell portion. You throw away most of that once you've concentrated and processed that bone marrow for the stem cell rich portion of that bone marrow. And then that is injected into the area where it's needed to stimulate healing.
So
that is
bone marrow derived.
Bone marrow derived cellular therapy.
Most popular.
That's what most clinics are doing.
Right.
The reason for that is now the FDA, and this is a whole nother conversation, but the regulation of cell therapy.
Right.
The FDA has flip-flopped. So there was a time when they said that bone marrow aspirate cell therapy or bone marrow derived stem cell therapy was okay, and that adipose derived stem cell therapy was not okay. They have since they've changed since I've been doing this for about a decade. They've changed this now 3 times. Their current guidance, which was put out in 2020, is that neither bone marrow nor adipose should be being done.
Adipose being fat.
Fat.
Right.
So most clinics do bone marrow because the initial FDA guidance was that was okay. They basically say, if you're doing bone marrow, we're going to leave you alone. But if you choose to do something else, we say that's a no-no. The reason why I'm going into this is that in most places, when you have a stem cell clinic, they're either going to be selling you bone marrow derived cell therapy because of that sort of initial guidance from years ago,
right?
Even though it's been changed.
Well, and you're saying now, as of 2020,
they said, yeah, they said even bone marrow derived, they're not okay with.
And so what does that mean? They're not okay with?
They say that clinics shouldn't be doing it. And now this gets into who really regulates medicine. Yeah. The reality is that the FDA does not regulate the practice of medicine in this country. The state medical boards regulates the practice of medicine in this country. And so there are some states like Colorado, California, Utah, where the medical board is open to these kinds of therapies and allows free use of them, frankly, because they understand, I think, they understand the therapies. There are states like Virginia, New York, Pennsylvania, where your heart, now New York's different because of New York City, so the city itself is a little more progressive. But you go to upstate New York, like you will not find you're hard pressed to find a stem cell clinic. Then there are other states. I'm listing those because I have clients in those states. I'm familiar, ozone's not allowed, stem cells, and that's because the medical board, which is at the level of the state government, is the one sort of setting the rules for what they allow their physicians to do.
Right. Like in the state of Iowa, like while I was writing my book, I did research on naturopathic medical doctors, and it's illegal to practice naturopathic medicine in the state of Iowa.
Right.
Because that's a state law.
Yeah.
Right.
And so, there's, and then this confuses most doctors. Like I didn't understand this when we started our clinic, I had no true understanding of this, but this is because I've been through the system and we've had to look at these therapies and be like, this is a great therapy. We need to do this in the clinic.
Right.
And then you have to figure out, well, the FDA says we shouldn't be doing this. So can we really do it? And why? And what's the risk? What's the risk for us? What's the risk for our patients?
Right.
And so,
but the state of Colorado
and the medical board has always allowed us to do our malpractice, so like our malpractice insurer, like we have to, we're like, well, what are you doing? Like, this is what we're doing.
Yeah.
If we're going to have coverage, you have to tell them what you're doing. And so, there's no like hiding what we're doing if you're honest about it.
So out of all the 50 states, like how many of those have medical boards say that it's okay?
I think that's shifting.
Okay.
But it's still why cell therapy is not widely available. There are many medical boards they're scared, they don't understand.
Right.
They see this FDA guidance and they're like, well, we're gonna follow that.
Right.
And so anyway, so bone marrow therapy is a good therapy if that's all you can get.
Okay.
And in my opinion, it's the worst of the options because of its potency of the cell that you derive, not just in numbers, but the healing ability. So bone marrow, when you're looking at mesenchymal stem cells, if you just want to look at numbers and you compare how many stem cells do you get out of bone marrow versus fat, from the same volume of bone marrow, you get 1/500. So for adipose, I'll go the other way around. For the same volume of bone marrow to adipose, you get 500 times the number of stem cells, mesenchymal stem cells
from fat. That's a big.
So it's a huge number. Right. It's a huge number. You're talking 200th.
And that's like, apples to apples on the volume. Is the actual extraction process? Is that like?
So the extraction's easier.
Yeah,
it's less invasive.
Yeah.
To get bone marrow, you need to sedate most people.
Mm-hmm.
It's painful. Right. You use a hammer, you hammer through the bone. I mean, it's not like somebody who knows what they're doing. It's a safe procedure to do, but fat's right under the skin. It's plentifully available. It's very easy. The complication rates, like when you go into the pelvis, if somebody doesn't know what they're doing, and even somebody who knows what they're doing, if your anatomy is a little funny, you can end up in the abdomen. And so like visceral puncture or like that can happen. That could also happen if you do liposuction on top of the abdomen. But if you get fat from the back of the love handle, you've just cut risk of complications way down.
That's where you guys take it.
You go a little deeper, you hit some muscle, it gets a little bruised, like no big deal.
Okay.
So anyway, so it's easier to get, it's less invasive, you heal faster, you get 500 times the number of stem cells. And the potency of the stem cell, meaning the healing ability of each individual cell. So if you took one of those bone marrow-derived mesenchymal stem cells and one of those adipose-derived mesenchymal stem cells, and you looked at how potent, the healing ability of each cell, fat has a potency that is preserved well into the late years of life, meaning 70s and 80s. Whereas bone marrow, because it's contiguous with the circulation, so your bone marrow supplies red blood cells, white blood cells, platelets to your circulatory system, and stem cells. So a lot of the circulating stem cells that you have floating around in your blood looking for injury come from the bone marrow. And so what that means is over your lifetime, those mesenchymal stem cells that live in the bone marrow have more of a demand on them. And so as you get to your 40s, 50s, 60s, their healing ability has been diminished because you've been using them more. The stem cells sitting in the fat are sitting in the fat. They're lying latent. They're not doing much. And so what that means is when you get to the time when you actually need those cells, the mesenchymal stem cells in the fat have more healing ability because they haven't been using that over the younger years because they've basically been sitting in the fat doing nothing.
Got it.
So, I would argue that adipose-derived cell therapy, and it's not just my opinion, that there's a lot of data, like this potency issue, these numbers issues, this comes from bench and clinical research. And so what we do almost we can do bone marrow. I haven't tapped a hip in years because fat's a better option. It's easier to get, it's safer, and it's more potent.
Right.
So why wouldn't I use that?
Yep. Got it. So this is something I've been talking to friends and family for a while. I've mentioned to you, I've been wanting an excuse, a reason to get stem cells, not to just throw money away because it is an investment.
Yeah.
But because I want to invest in myself and my health now and in the future. And so there's a value in the idea of banking them. And I want to,
so that's another step.
Yeah. I want to hear about that.
And then there's one other thing we should mention. Sorry, I don't want to cut you off,
Yeah.
but that's the allogenic products, the umbilical cord, the placental derived
embryonic.
products,
Yeah.
And so, different than embryonic. That's a semantic term, but anyway, I didn't want to.
But
so we should get to those. So again, like
illegal?
Stem cell therapy, no.
So
embryonic stem cells, yes, meaning coming from, a fertilized ovum. So if you took you could do a procedure where you stimulate a woman's ovaries with, hormones, like what they do with IVF, and they produce a lot of follicles or eggs, for lack of a better term, and you can surgically then harvest those eggs, and then those eggs could be fertilized with a sperm. Now that's an ovum, and then that ovum, that single cell, can divide and create a human being or a whole, whatever the animal that ovum comes from, can create a whole new being. Those kinds of stem cells are illegal to use in the United States, and I would argue there's a perception that they would be better, but when you actually when you read these horror stories about somebody went abroad and they did a stem cell procedure and they came back with some bizarre tumor growing in their spinal cord or in their abdomen or somewhere, it's because those cells are totipotent. And I guess the way I explain this is, if you take one of those cells out of the environment, like that cell has an amazing ability to create a whole being, but it will only do that in a womb, right? You can't take that cell and put it in a petri dish and just give it some glucose and expect it to create a being, right? Like it needs the right environment, and it's the interaction in that environment that enables that single cell to create a whole being. If you pull that cell or any one of sort of the subsequent early cells, so that in its early division, it divides to 2 and then to 4 and then to 8, and gradually it turns into hundreds of cells. But those so embryonic stem cells imply those early cells.
Right.
There are clinics where people can go. I don't know of any that exist anymore, because those therapies are very, very, like, one, they're not ethical. 2, they're very, very dangerous. They don't result in healing, because you take those cells out of that environment and you stick it in an adult body. That cell it's like taking me and putting me on the subway in Tokyo or, dropping me somewhere in Bombay. Like, I don't speak the language. I don't know where I am.
Right.
Like, I don't know where to go. Like, something bad is way more likely to happen.
Right.
Right. And so the same thing happens with those embryonic cells.
Got it.
So embryonic cells are those early fertilized egg cells. Nobody should ever do that because bad things happen.
Got it. Yeah. I had heard about some bad press about stem cells, like some podcasts that my sister actually told me about called Bad Batch, about some horrendous stem cell experience that someone had that was most likely the embryonic.
Yeah, absolutely.
Yeah. Because there's in terms of risk with bone marrow or the adipose derived, are there risks?
So any medical therapy, there's risk, right? Like, but so I'll tell you, like the paper I just presented at this conference I mentioned earlier, 550 people injecting degenerative spines, lumbar spines, followed out to 2 years. The complication rates, when we compare it to standard of care therapies, we beat every standard of care metric. It's pain, bleeding, and infection. And infection is less than 1% of the people had a superficial skin infection at the harvest site. Not where we injected. Nobody ended up with a spine injection. Nobody got meningitis. Nobody had an epidural abscess. Like, you do 550 steroid injections, somebody's going to get an epidural abscess. It's just going to happen.
Right.
This is where I alluded to the stem cells. They're smarter than we are. It's not that the doctors, I mean, we like to think we're better, right? But the reality is, like, we're no better technically than anybody else who has similar training. It's that what we're putting in there is so smart and so intelligent, and it helps mitigate these risks that, if you hit a blood vessel in the spine, they're helping to heal it and prevent it from becoming an epidural hematoma. As it's happening.
Right.
So the cell itself mitigates these bad, dangerous risks that you see in other, like if you did a similar number of traditional procedures, you're going to see an epidural abscess or an epidural hematoma. It's going to happen, but it's because you're injecting a synthetic.
Right.
These cells, what they do is they heal tissue.
Right.
And so the complication rates when you use stem cells are so low and they're so safe, even out in the long term, that it's really, they're the safest. It's not just my opinion. It's what the data shows. If you're going to have an invasive procedure, it's safer to do with a stem cell than it is to do with anything else.
It makes sense. But
when you think about it, and when you understand what's happening, it totally makes sense.
Yeah.
And so nothing's no risk,
right?
But there is low risk as you can get.
Mm-hmm. Okay.
And so anyway, so bone marrow, fat, and then what we call placental derived. And so placental is different than embryonic.
Got it.
Because you've gone through the whole development process. And this is hard for some people, but when the baby's born and the placenta that comes out with that, all the stem cells that are left in that are adult stem cells. They're adult mesenchymal stem cells. Even though it's still a child, a baby, the baby has to develop into adult years. But all of those cells are differentiated well beyond the point of those very early embryonic cells. And so you can actually use placental-derived, amniotic fluid-derived, umbilical cord blood-derived cells because they're adult mesenchymal stem cells.
Are they more powerful than like my 35-year-old?
So in theory, yes, the cells that were disposed of in the placenta when you were born, they should have had more potency than cells that you have currently in your body. Again, fat preserves potency longer,
sure,
because of the demand on them. But the future is really, you're born, your placenta, your entire placenta should be banked.
I was going to ask, like that's
and from that you could culture expand your adult mesenchymal stem cells for the use for the rest of your life.
So let's say
that's actually you can do that now.
I was going to ask, like,
that's possible.
Are people doing that? Like, are there just specific companies?
There's only one. So this then gets into the way we. Sorry, we're kind of getting ahead of ourselves, but the answer is yes, that can be done. There's one cell bank that I know of that's doing that.
Okay.
And so if you're pregnant and you want to do this, it's not like most of the umbilical cord blood, banking places will not harvest and maintain the cells in a way that will enable culture expansion of mesenchymal stem cells for use again and again and again. There is one cell bank currently operating in the United States. It's American Cell Technologies. They're in Florida.
Okay.
ACT, you can look them up online. That's where we bank our stem cells.
Okay.
So they bank placentas and they bank adult stem cells, and they will culture expand them. And so we're now getting, again, sort of deeper in the weeds. But before we go there, I'll say you can also get, people will donate so at birth, they will donate their placentas. There are labs that will take that umbilical cord blood, the residual amniotic fluid, and the tissue from those placentas and isolate a cell product that is rich in mesenchymal stem cells. And those can be used and bought and used and injected currently in the United States. And so we have them sitting we have some sitting in our freezer in the clinic. They can be very effective in the right scenario. This is where, like I said earlier, like most clinics do one of these things. Most clinics, they learn how to do bone marrow a certain way, and that's what they do.
That's all they do.
A lot of clinics are using these placental products because they don't need to know how to do the harvesting and the processing. Right. So, you buy an off-the-shelf product, you draw it out of a sterile vial, and you inject it in a knee or a shoulder or a ligament, and they can affect healing, and they're potent. And there are some scenarios where we use those products.
And those are usually donated from, you said, placenta.
Okay. And so there are a bunch of different tissue processing labs in this country that make those products that we can get, and so we can order them and use them. And sometimes
one question.
Yeah.
So how would placenta stem cells compare to a 20-year-old, a 30-year-old, a 35-year-old stem cells in terms of potency?
So there's for the potency issue, cell for cell, we assume that the placental product is more potent, but that's only one of a few factors, because when you process these tissues, so whether you harvest bone marrow and you process it, you harvest fat and you process it, or you harvest umbilical cord blood from a donated placenta, you can process the cells to concentrate the stem cell rich portion, but you cannot completely exclude all the other cells from that final product, meaning you're going to get some other cells other than stem cells. You're going to get some red cells, you're going to get some white cells, you're going to get some fibroblasts, you're going to get some endothelium. So you're getting a mixture of cells. In the placental products, there is a mixture of cells as well. They're not just mesenchymal stem cells. You're going to get some red cells, you're going to get some white cells, you're going to get some endothelium. Why is that important? That's important because if it was just a pure mesenchymal stem cell, those can be used between me and you. If it's just if it's just your pure mesenchymal stem cell that's been cultured, you could put those in my knee and they should work to affect healing without an immune response.
This was one of my questions. So I was wondering if my stem cells, my mom could use my stem cells if I bank.
So the answer is theoretically yes. In practicality, currently in the United States, we don't do that. And the reason is that joints are immune privileged areas. And this starts getting into, and that's part of the reason why they have trouble healing. They have very poor blood supply. The immune system doesn't penetrate them very well. And that's why infections, when they happen in knees and shoulders and hips, are like really devastating. And so there's a layer of protection for immune interaction. Meaning, if you wanted to transplant a kidney, right? like you need a match.
Right.
You need a hot, and it's not just a basic HLA match. There's a very sophisticated process of tissue matching. And even when we do all that, sometimes it still rejects, right? And this is where we get into, like, we only understand so much, and then you can only test and replicate so much. And then there's a portion that is either unknown or we know but can't replicate synthetically or a laboratory test. See what I'm saying? And so even this is why you can do all the cross matching and find a donor and still have rejection.
Right.
A mesenchymal stem cell has a cloaking from the immune system, and this starts getting into there's a couple of sophisticated mechanisms that the stem cells use to not draw an immune response from, like if your stem cells were banked and cultured and you had a pure mesenchymal stem cell product that, to inject in my knee, that can be done. Give me those cells IV once or twice, probably fine. And maybe even more than once or twice, probably fine. But there is, on some level, an immune reaction between somebody else's stem cell and your immune system. And it's relatively minor when you go into immune privileged areas. It's different if you use them systemically.
Got it.
And it's different how many cells you use and over how much time. So that and this is an area where the research, we don't have a lot of research.
I would imagine.
And this is, part of the problem is clinics like Panama and Costa Rica and Colombia, they don't publish, they don't publish long-term outcomes. And it's too bad because there's a lot, we could know so much more, right?
Yeah.
Than we do in those areas. And so our preference in Rocky Mountain Regenerative in our clinic is to use your own cells.
Right.
Unless there's a specific reason where somebody else's cell might be better. And so what's a specific reason? You're 98 years old and we've used and now this was in the days before banking, because banking changes this equation, but you're 98 years old and we've tried your own cells and they're shot. Even the fat cells are shot. And you're like, am I worried about an immune reaction 7 years from now? No. No. I just want this to stop hurting. Right. You have that conversation with the person. They're like, forget it. I'm not living another 7,
quality of life.
I'd rather be pain-free now. And so that's not the only, but there are scenarios where allogenics or those placental products are good options for people. You skip a harvesting procedure. Somebody who would have difficulty getting through harvesting procedure, somebody, particularly for cosmetic, superficial things, you have a little bit more liberty in terms of the safety and the immune. If you're using them topically on the skin, that appears to be way safer than injecting them into your body. Okay. And does not appear to trigger these immune reactions.
So you can have an immune reaction from
a placental
as well.
And so particularly because the products that are available now in the United States, there's other cells in there. So you're not just getting pure mesenchymal stem cells. You're going to get some fibroblasts. You're going to get some red and white cells.
Right.
Those cells will absolutely generate some sort of immune response. Now, if they're done intravenously, right? Now you put them in a knee in an immune privileged zone. That's been done for years now, again and again. We've done it in the clinic. You can get away with that even multiple times without an issue.
Okay.
But again, my personal preference
is to not do that
unless there's a specific reason.
Well, I mean, my reason would be funds, investment. It is I intend to, it's a big priority for me to do this, to bank with you all soon. My goal is sometime this year, actually. So, I mean, I could pull the trigger just about making it happen, right? And so I want to talk about costs and the banking process and then how the injections work. But yeah, that would be my interest is oh, Mom, here's your Here's your birthday present.
Right. Get your stem cells banked.
Avoid shoulder surgery, a second shoulder, or, for
Absolutely.
avoiding knee surgery.
Or even if you need, so like I probably talked to you, like I ruptured my ACL, it was gone. I needed surgery. I cut my recovery time in half by doing a stem cell infusion 3 days after my surgery, and why? Because I'd done my other ACL 5 years prior. So I know I did the exact same thing, same surgeon, same like everything the same. I'm even 5 years older, and I cut my recovery time in half.
Wow.
By doing 30 million of my own banked cells 3 days after surgery. They're going to enhance your healing.
Right.
And so anyway, so to get back to the original question, so stem cells, bone marrow, it might be all you have available. It's a reasonable option if it's all you got.
Okay.
And if you can do fat, way better. Allogenics, which come from placental, some type of placental product, are an option, and that's what you'll find a clinic. A lot of clinics just do allogenics because they buy them in a bottle, they draw them up, and they inject them. Super easy.
No harvesting.
Harvesting, no nothing. It's way easier to learn.
Yeah.
Now when we talk about banking, this is where you actually take some cell, whether it's placental tissue when your child's born, or your own cell, either from bone marrow or from fat, and we send that to a cell bank that takes that tissue, processes it for the stem cell rich component, and then does a culture process to isolate the mesenchymal stem cell and culture expand that cell. And what they do is they create a master bank of cells. It's basically like a library of cultured cells that are frozen, that can be thawed, cultured again for therapeutic use. Mm-hmm. And so this is when, TJ, when you talk about banking, this is what we're doing mostly now in the clinic for a couple of reasons. One is one harvest, you bank your cells, you culture expand them, you get hundreds and hundreds of millions of cells that you can use over decades.
Hundreds of millions.
Yeah.
So maybe like a billion, or more than a billion?
Well, the answer is everybody's different.
Yeah.
So,
and they would actually quantify it, like.
Oh yeah. And so the way, the way it works is we harvest tissue, we send it to the cell bank. They have a GMP facility, which is, negative airflow, like the mask, the hoods, the whole bit. They're in a sterile GMP facility. They culture expand those cells and freeze them and save them for you. You draw on them 10 million at a time.
Okay.
So they've sort of arbitrarily come up with, and they actually put 12 million. So I know the medical director, I know the people who run that bank. They're smart. They know what they're doing, and they do a good job of it. So you're when they say you're getting 10 million, they buffer that by 20%. So you're getting about 12 million cells per vial or per dose when you draw on it. And so they will allow you to draw up to 50 million or 5 doses at a time. And if for specific reasons you can draw more. These are sort of arbitrary numbers that they've come up with because even though they're FDA registered, they've been inspected by the FDA, all these tissue processing, like these people who are making umbilical cord products, they have to be FDA registered. And so the FDA has been through and inspected them. And so like, I think the FDA probably doesn't really understand what they're doing personally, because the FDA for sure would say no to this. The people know that this is going to happen. And this is a whole nother conversation about going back to the FDA rules. Like, so how can we break the FDA rules? Like what's the mechanism there? But we'll put that aside for now. We can get into that if you want. But you can now, here in the United States, harvest tissue, get culture expansion, and use your cells by the tens of millions again and again and again. How long your cells will culture and last in culture are different than how long placental cells, and are different than mine. And so how many total cells will you get? Well, everybody's a little different. In general, the healthier you are, the more potency those cells have. We've never had to reharvest a client. I know clinics who it's routinely they have to reharvest because, well, one, again, most stem cell clinics are stem cell clinic. People go in, they're like, I want you to inject my knee. And they're like, great, well, let's bank your cells. We'll inject your knee now. If you ever need to inject it again, we can inject it again without a harvest. Great. They're not doing any of the health optimization.
Right. So you're saying your patients are so healthy, they haven't needed,
And so what happens is, for most people, and now Boulder people are healthy, healthier in general. And for most, even, people who aren't sort of the typical Boulder health nut, athletic, being stringent about their diet, it doesn't take a lot of work to really move the needle metabolically.
Right.
And so, we started as a stem cell clinic.
Oh, was your niche.
That was really we did what we learned, which was, stem cell clinics are sports med places.
Right.
And then we very quickly, and partially it was because we discussed earlier is like, well, but health's more than just drawing a cell. And what we saw very quickly was like, if somebody's not optimized and you do a cell therapy, their outcomes are not as good.
Right.
And so when you have a conversation with somebody, you say, like, you're looking at investing thousands of dollars because you're in a lot of pain, your back, your knee, your neck, your shoulder, your hip, whatever.
Right.
Let me propose to you this scenario. Let's spend 6 to 9 months cleaning up this metabolic mess, lose 10 to 15, 20 pounds, get your A1C down, get your inflammatory markers down, do a cycle or two of autophagy. And guess what? You might not, what we found with a lot of those people is you don't end up even needing to do an injection.
Right.
Right? And when you do the injection, you get a way better outcome.
Right. So your health, your state of health going in to the harvesting affects the quality of the stem cells.
Exactly. Right. It's your healing. And so the way, the essence of this is your stem cells are your healing ability.
Right.
And the healthier you are, the better your healing ability is. And so if you're going to invest time, money, and energy in a stem cell procedure, why wouldn't you optimize?
Optimize
first. And 99.9%, even people who, they come in, they're overweight, they're like coming up from Aurora or, from a different area because they've heard we're good at what we do.
Yeah.
And you sit them down and you're like, listen, you're telling me your back's killing you. I'm going to be frank with you. You're 40 pounds overweight. You're on a laundry list of drugs, all of which inhibit stem cell function.
Right.
I can do, like, that's a good scenario where, like, if they can't, like, an umbilical cord product, great scenario, right, for that.
Right. That makes
like,
sense.
if you really need it, like, let's save you the money on a harvest. Let's do this one-off injection. And if you're willing to put in 3 to 6 months of work, we can get you to a different place where you might not even need the injection.
Right.
And if you need the injection, your outcome's going to be so much better. There's maybe one person I can think of in about a decade who was like, no, I'm not interested in that. Like, who wouldn't be interested in that? Most people are like, wait a second, you mean you're saying I should get off these drugs? And I'm like, yeah, in fact, you don't need most of these drugs. We can get you off of most of these drugs. And most people are like, my doctor's never told me that.
Yeah.
I'm like, well, none of these drugs are curing your condition. They're mitigating your symptoms. You can cure your condition by going back to the fundamentals.
Amen.
So anyway,
Love it.
Anyway,
for someone like me, and so it sounds like I'm humbly pretty optimized.
Yeah.
And
you are.
A lot of the people you work with, I'm sure are. You started as a sports medicine practice. You've worked with, I know, lots of athletes.
Yeah.
My wife and I run a custom performance chef company for pro athletes across the country. So for someone that's like a pro athlete or like me, like we're already really optimized and are interested in taking it to the next level.
Yeah.
with stem cells. Is there a protocol you would suggest going into a harvesting to even get that extra 10, 20%?
Absolutely.
What does that look like?
Number one, that's a fast for two reasons. One, if we're harvesting cells, you want to get rid of the junk.
Right.
So a cycle of autophagy, super helpful.
Like the 3 days up until, and then like not eat until after, or like.
But there's
prior.
another component to the refeed when you refeed from a fast. So fasting, when you fast, you're triggering starvation. The starvation state triggers the autophagy because you have to self-consume. Right. You're like, I'm not getting calories from anywhere else. I have to get them from inside.
Burning your own body fat.
So you burn your own, and this is the beauty of the starvation-driven autophagy, which is if you look at the quality of your cells in your body, you have a few trillion cells in your body. They're not all physiologically on the same level. Some of them are healthier than others. And so you have A players, B players, C players, D players. The F players, I would argue, are frank disease, and that your immune system should be eliminating. Right? Should be, being the operative word. But if you get rid of the D players, so if we're going to harvest tissue, right? Do you want to harvest A, B, C, D and some F?
No.
Or no, you want to harvest A and B.
Right.
Right? So autophagy helps cut down on the lower, like
the D's
that's
and
what
F's. Yeah.
that's what autophagy is.
Right.
Is your body is selectively picking those off. Then when you refeed, your body knows because it's been self-consuming that it has to rebuild. And so one of the most potent components of the fasting is not the fast itself, it's the rebuild. Because in the rebuild, if you look at this data, the number of your stem cell counts quadruple, it's 5x for a limited time in the number of stem cells available. So your body multiplies the stem cells that it actively has active in your system to 5x baseline to rebuild. And that happens over a 2 to 3 week period in a refeed from a starvation period. So
over a 2 to 3 week period after
yep. So you starve, you fast, you refeed. It takes a few days, but usually, within 72 hours of refeeding and your body having energy again, it 5x's its stem cell counts because those stem cells are going to go out and replenish what was consumed.
Right.
And so then I ask you, if we're going to harvest stem cells, why wouldn't we harvest
at the peak
much
as possible? Right. So looks like two or 3 weeks before?
Usually the way I would schedule this is fast and then, about a week later harvest. 1 to 2. So within that week to 2 weeks after, you harvest when you're peaked.
And are we talking 3 day, 72 hour?
Yeah, 72 hours is enough. We'll tell people to push it to 4 days if they can. It could be 4 days of 800 calories, 2 400 calorie meals. The lower you can push that calorie count, the more autophagy you can get.
Right. And
so some people like 800 calories. It's enough. It will get you what you need. But the lower you can drive that calorie count, the more autophagy, the better. So, a lot of people would do like 3 or 4 days of 600 calories or 4 days of 400 calories, 4 days, whatever you're capable of doing. So that's step one. Step two is, there are peptides that you can use that also help push.
To blunt the hunger or what?
That help stimulate. Yeah.
Got it. Like which ones?
So we tend to use, typical protocol we use is like BPC 157, thymosin beta 4, and CJC ipamorelin.
Those are shown to boost stem cell production.
Well,
Okay.
And CJC ipamorelin in particular, because it works through growth hormone pathway.
Yeah.
And BPC and thymosin beta, just because they help promote soft tissue healing.
Right.
And so, what we would typically do, like somebody who's like all in, tell me what, like fast, we'll start peptides, so if we're going to do, let's say stem cell harvest on the 15th day of the month, on day 1, you start the peptides. You continue those all the way through the whole month, pre and post
Got it.
harvest. You fast sometime in week 1, refeed from your fast, harvest around day 15.
Got it. Cool.
And so that's sort of like a simple,
Yep.
easy, and I'll tell you, is there another clinic in this country or in the world that's doing that? Not that I know of. Unless they've heard me lecture and they're adopting.
Yeah.
Some of them might do part of that.
Right.
But this is where, I have a lot of friends, people who I learned from, people who I considered mentors, who are like, they have to reharvest their bank patients 2-3 times.
Yeah.
It's like, why not?
If you follow the right protocol, if you're dialed in, super healthy going into it, you shouldn't need
your cells will last longer in culture.
And you also want to, correct me if I'm wrong, but I heard this from another doc that I've interviewed, Dr. Mazzola, who's regenerative sports med doc here in Boulder, that going into a lot of treatments, but also I think harvesting the stem cells, you want to completely avoid for a long time any sort of steroid injections.
So
like cortisone.
So this gets into how stem cells heal.
Yeah.
And the answer is yes. In general, anti-inflammatories, steroids are the most potent because non-steroidal anti-inflammatories, I mean, that's what they are. They're non-steroidal anti-inflammatories. Steroids are the most potent. And there's different types of steroids, right? We're not talking anabolics.
Right.
We're talking the cortisol, the prednisones,
right?
Like those glucocorticoids, not the mineral. So anyway, this starts getting into what type of steroid, but yes, and that's more for the healing process. We in general would recommend avoiding, aspirin, naproxen, ibuprofen, prednisone, any steroid injection prior to a harvest.
Like how far? Like months? Or?
It depends what.
Yeah.
And it depends what we're doing.
Okay.
Meaning, so for example, you can do stem cell procedures with somebody on a steroid. Meaning, for example, chronic pulmonary fibrosis. It's an incurable pulmonary disease. People are going to die from it.
They have prednisone.
They're on prednisone chronically, right?
Right.
And pulling the prednisone advances the pulmonary fibrosis.
Right.
And so guess what also helps to mitigate fibrosis, which is scarring of the lungs? It's stem cells. And so you can still harvest and deploy stem cells while somebody's on prednisone.
Okay.
It does, we believe, mitigate their healing capacity. Mm-hmm. But if you can avoid it, yeah, absolutely. And so this is where it depends on the scenario for most people.
Yeah.
You don't want to have any prednisone or.
Yeah. Well, so let's say someone had a cortisone shot in their knee because there's just so much pain.
Yeah.
But they also want to do stem cells.
We would usually recommend at least 3 months.
Okay.
You can do it sooner than that when you really need to. Yeah. It's not ideal.
Right.
But yeah, that's sort of like general rule. 3 months for like if you had a spine injection or a joint or ligament injection of steroid. Mm-hmm. It really clears faster than that. But we like to add a little buffer just to make sure like all the effects are out of the system and out of the area where they've been, put.
Makes total sense. Amazing. I'm sure we can go even deeper.
Yeah. We could go on forever.
This has been fun on stem cells. I was really excited to get into that. And like I said, I'm interested in personally doing that. And so you've got patients locally, of course.
Yeah.
You're mostly, like you said, you operate outside the system, cash pay, which I'm all on board for. I don't have insurance. Yeah. So, I mean, I'm all about, direct primary care and that sort of.
And what I say is, there are cost sharing. So this, I don't want to drag this out too long, but, I don't know if we're doing okay on time.
Yeah.
So insurance, there are a couple of insurers who are starting to cover PRP.
Okay.
Which I think is great.
Yeah.
And they don't reimburse at a level, frankly, where you can get really high quality PRP. And so, and now this starts getting into parsing, like you can, like so I know guys at the gym there was somebody down in Castle Rock who's doing like $400 PRP injections, and
which is low.
It's super low.
Right.
And what I would argue is like that you're not getting PRP, because what they're doing is they're drawing blood into a purple top blood tube, and they're spinning it with a centrifuge that a lot of labs like LabCorp and Quest will give away for free. And so, and they're taking that spun blood and then putting a needle and drawing out sort of the buffy coat, so the layer of where the PRP is supposed to live. But you're not getting 7 to 10 time platelet concentration with that. And by definition, PRP is 7x baseline platelet. You see what I'm saying? So for the therapy, but based on the definitions, you're getting a platelet injection. You're not actually getting PRP. There's still some regenerative capacity there.
Sure.
Right. And so you can get a result.
Right.
But, at least 7, like, so as a general rule, like for proper equipment, processing costs, like around $700, you could get a good quality PRP product. We're a little bit more expensive than that. But we also, I would argue, so we've never published this, but we get much higher platelet concentrations from our processing. And so there's a reason why it costs a little more.
Right.
But that's like, when you go out to dinner,
right,
you could go out for a cheaper or more expensive dinner, and that's that's your choice. Right.
Exactly.
And so, forget why I got into that, but
we were talking a little bit about insurance coverage.
Oh, and so, cost sharing programs, like, so Christian Health Initiative, so CHI, you don't have to be, a member, but they actually cover, they cover stem cell procedures.
I was
in their cost sharing program.
Okay. Really?
Yeah, they do. And so Sedera is another one. I don't know for sure that they cover cell procedures, but,
this is medical bill sharing, right?
It's not insurance.
Right.
There's a premium like system. It's way more. So I actually went on, I'm not like, particularly religious person.
Right.
I'm a spiritual person.
Yeah.
We don't go to church every, Sunday. But when I left the hospital, transitioned into the clinic, I went on to CHI, and I was worried because I was like, is this really going to work? It was 4 times cheaper than any of the other insurance options available to me. And my experience was fantastic.
Yeah.
And they cover cell procedures.
Wow.
So there is an option out there, for a cost sharing plan that you can get some of these procedures covered with.
I was a member of one of them. I can't remember the name now. I don't believe it. Who knows if they covered that? There were a few questions I wanted to circle back around regarding stem cells. But first, on the PRP thing, we talked about my knee. So right before we hit record here today, I actually showed Dr. Voss images of a recent MRI I had like less than 2 weeks ago on my left knee. I've had nothing major, but just some annoying pain. I've been skiing a lot in the mountains, all that downhill drive on the Platella, and my first marathon I ran like a decade ago. At mile 12, I was in excruciating pain, and I was popping cannabis edibles to get me through the rest of it, man. Like I was just like, numb this shit. I'm not stopping. It was actually in Colorado. It was a coast to coast marathon where 4 people ran a marathon across one day, and like I had the 4 a.m. to 8 a.m. shift, and you hand like a baton off to the next person. It was a really cool thing led by a group in Des Moines. So I've woken up, I got the MRI, wanted to figure out like what's actually going on, because like tests don't guess, right? Like the imaging, that information is worth its weight in gold. And so I invested cash pay, $450 in an MRI, and I got results that I have chronic tendonitis, which is called tendinosis, right?
Yeah, it's when the tendon starts thickening because it's been going on for so long.
Right. And that's of the patella tendon, here in the knee, and we're talking about strategies to hack that. And it sounds like PRP could be a
PRP will work for that.
good option for that. Right.
Yeah. Stem cells are better.
Mm-hmm.
They're more expensive.
Right. Yeah.
So, and that's where I was saying, like, you could get away, like PRP will work.
Okay. Yeah. All right. Well, I got to get scheduled for
And
that then here.
yeah. And, and if you're like, if I'm going to bank,
Yeah.
I mean, that's one where, you inject the patellar tendon, you have at least a 2-week downtime.
I've heard that.
And then,
I'm not crazy about that.
Well, but this is where you bank, you shockwave, and you do IV, and you can go work out after you leave the clinic. So this is where, we didn't really get into,
Meaning
but
stem cells wouldn't require 2 weeks off
yeah,
versus the PRP.
if you do them IV.
Ah.
And so this is where you can, I mean, we talked about shockwave briefly, but
Yeah, let's
shockwave,
talk about that.
shockwave uses ultra high frequency energy
Mhm.
and pulses it into your tissue.
Mhm.
And really what it does is that high energy creates a tissue oscillation, for lack of a better description. Healthy tissue, you can oscillate all you want. It doesn't hurt. And injured tissue, it hurts like heck.
Yep.
But that process in of itself is therapeutic, meaning you stimulate healing with that. Improved blood flow, growth factor release, stem cell activation in that area. And so you can heal, these kinds of injuries with just subsequent interventions with shockwave.
I can attest. I mean, you treated me with shockwave on my arm, my neck, my shoulder. I have a slight tear in my infraspinatus, my ankle. I've noticed a lot of benefits.
Yeah. And so it's a good therapy in and of itself, but what it does is it's kind of like prolotherapy. Prolotherapy is where, we used to take a needle and like you make a micro injury by just poking that. So prolotherapy on that tendon would be, we numb up the skin, you stick a needle in there and you just jab that tendon a bunch around where that inflammation is, where that tendinosis and tendinitis is. And then you leave it alone because that injury creates a healing response, and that healing response creates additive healing. You heal it more than you actually damaged it.
Okay.
Prolotherapy sucks because it's painful and you got to do it.
Is it like dry needling?
6, 12, 18 times. It's like dry needling, but it'd be dry needling like we'd have to go into the patellar tendon.
Okay, because I got something in here, dry needle, just a couple of days ago at my physical therapist.
Yeah.
But
so dry needling can stimulate a healing response. They're usually using like an acupuncture needle. And so prolotherapy, I would use a much higher a larger bore needle. So it's similar, but it's different.
And I can be awake?
Yeah, most people are awake. We don't do it. I don't do it anymore because it's painful. There's a lot of downtime, and you got to do it again and again and again and again and again. Whereas like that's one PRP, done. But shockwave, to treat that with shockwave, I don't know, maybe 6, 10, somewhere between 6 and 10 shockwaves, maybe more depending on how it responds. But if you have your stem cells banked, we shockwave that area, basically light it up. You trigger an inflammation reaction, and you give stem cells IV. The stem cells will target to that area.
Ah, that's the magic of the human body.
Yeah.
Wow.
And so we've been doing this for years. It's highly effective, and it works great for athletes who are like, I'm in a training camp, or I've got my races on X date, and I just partially tore whatever.
Right.
And this is like pro athletes and some of the fighters we treat. They're like, I'm fighting. Like, what can I do? Yeah. And then it's like, well, if you're banked, shockwave, IV, go work out.
That's the protocol.
Love it. But with no tissue trauma. I mean, it's not ideal to be working out, at 100% on a tear.
Right.
But you can brace, be careful what you do with that leg, still continue to work out the rest of your body, and heal that in a relatively short period of time. So with no downtime with shockwave and IV therapy. And so, do you see what I'm saying? Like no harvest.
Right.
So there's no downtime from the harvest. There's no downtime from an injection. We heal a lot of injuries like that.
Yeah. Yeah. Well, I love it. I didn't ask about exosomes.
Right. So
Baby stem cell, like what are those? How are they
yeah,
different?
well, the reason why I didn't include it in that spectrum of stem
Yeah.
cells is that there's no cell. So this gets into the biology of how the stem cell works. And it might be good to cover because the narrative that most people talk about with how stem cells heal tissue is wrong.
What is that?
So the narrative and what most doctors have and what most people on Instagram and Facebook and even the well-known people, who've publicized these therapies, they, I guess I would argue that most of them actually know this, but they've stuck with this narrative for so long they don't want to switch.
Okay. Yeah.
But so the idea is that stem cell is a cell that can turn into another tissue by definition. That's what a stem cell is. And there's a myth that so let's take your damaged patellar tendon, that if we were to take stem cells and inject them into the patellar tendon, that the stem cells get into the area of injury, turn into new tendon cells, and heal the injury by replacing damaged cells.
Yeah.
That's the narrative that's talked about everywhere.
Got it.
That's not how stem cells heal tissue.
Okay.
So then how do stem cells heal tissue?
Yes.
A stem cell, an adult mesenchymal stem cell, has the capability to turn into a new tissue, but that's not how it's actually healing tissue in your body on a daily basis. And it's not how it heals tissue when we inject them. When you inject a stem cell, or a stem cell naturally comes into an area of injury, what it does is it starts doing assessments of the damaged cells that are secreting markers of inflammation. If that cell that's secreting markers of inflammation is beyond repair, it's like imagine a brick that's just crushed and there's a couple fragments, like it's done. The stem cell will trigger apoptosis. It will cause that cell to die and have the macrophages come in and clear that cell out. Okay, so one, stem cells clear out the tissue that's beyond repair.
Okay.
Two is they find the cells that are damaged, that are secreting these inflammatory markers. And if in their assessment of that cell, they deem that cell salvageable and healthy, they will secrete exosomes onto and in that the cell. Those exosomes will bind to the cell surface and be absorbed into the cell, which provide the cell with what it needs to heal the damage that it has and allow that cell to have extended number of cell divisions. And so we all know that, like, you cut your skin heals not by a stem cell miraculously appearing and creating new skin. It heals through the skin dividing to fill in the gap. Other tissues work the same way. Tendon cells require division of those tenocytes.
Interesting.
What stem cells do is it allows the healthy cells that are in that area of damage to multiply more aggressively.
The salvageable ones. They'll send exosomes to help them multiply more aggressively.
Yes.
Okay.
Ultimately, the process is a little more complex than that.
Yeah.
But that's essentially what's happening. So it's through exosomal release. It's those exosomes that facilitate more robust cell division in damaged tissue. And it's this more robust cell division that fills in the damaged area.
Got it.
And so
can you get exosomes?
Yes. So you can, exosomes, your stem cell in your tendon is going to create the specific complement of exosomes that is needed for each individual tenocyte or tendon cell that it comes into contact with, that it deems is healthy and ready to divide aggressively to heal that injury.
Okay.
Why is this important? This is important because in the data that we've collected and that other people have collected, and this is a little bit of a tangent, but it applies, is that one of the complaints early on with cell therapy was that you're taking cells out of the body you're mucking with them, you're centrifuging them, you're doing this, processing them, and then you're putting them back in. How do you know it's not going to cause cancer? Right?
Mm-hmm.
Reasonable question. Well, we know because we now have a 15,000 person database that's over a decade old. And when we compare cancer incidence in the people who've undergone cell therapy versus the age-matched population, guess who has a lower cancer incidence? People who've had stem cell therapy.
Mm-hmm.
This gets into the stem cell has an intelligence that if the cell's not healthy, it will pull it offline.
Mm-hmm.
And so we don't have hard data that says that stem cells, when they're circulating through their body, they might be identifying cancer cells and triggering them to die or marking them for immune clearance. But that's a possibility of what could be happening, because not just our data, but Hernigue, so the founder of bone marrow, like the person who like bone marrow stem cell therapy was founded in France. So a French orthopedic surgeon named Hernigue. He started doing it in the 80s, and mainly for hips and knees, hip osteonecrosis. He published a 30-year review of over 3,000 patients that he'd done cultured bone marrow in the hip on his patients from the 80s, and showed the same thing that we showed in our spine paper, which is people who get stem cell injection are at lower risk for cancer incidence than the general population.
Wow.
And so I'm not saying that stem cell therapy is a cancer treatment,
Right.
but stem cells mark and trigger cells for apoptosis, meaning cell death.
Schedule cell die-off. Right.
And so
That's what causes cancer, is when apoptosis doesn't happen.
it doesn't happen in a cell where it should.
Right.
Or a cell that should be cleared by the immune system flies up, for some reason the immune system doesn't pick it up.
Right.
And so my point is, stem cells do way more, and this is not just me hypothesizing, they're not just like tendon injury repair things.
Mm-hmm.
They help the immune system function better. They help all tissues function better. And they do that through exosomal communication. They don't do that by turning into new tissue. Why is that important? That's why I could use your stem cells.
Mm.
Because your stem cells are not turning into new tissue in me. If they were, that would create tissue rejection in that new tissue.
Just like your example with surgery, like having a different new
an
organ.
HLA matching, you know, so you can use stem cells between people, because the stem cells are not turning into like my stem cells wouldn't turn into your adult tissue. My stem cells would heal through exosomal communication, your already adult tissue, which would divide better and more. And so it's your tissue.
Right.
So there's nothing to reject because it's yours.
Yep.
Do you see what I'm saying?
Yeah.
And so,
but can you get exosomes?
So
on their
you
own?
can get exosomes. So there are products. You know, the FDA actually so exosomes have front run the regulation. We've been using exosomes for years. You can grow a cultured mesenchymal stem cell in culture. They're constantly releasing exosomes. You can take that culture media, process that to eliminate any cell, ultrafilter it so that it's sterile, and then have a solution that is rich in exosomes that have been released from mesenchymal stem cells in culture. How is that different than the exosomes that are released? Is that the exosomes that are released locally when we inject stem cells are tailor-made for each individual cell that a stem cell has an interaction with. What you get in the commercial product is an aggregate of all the exosomes that the stem cells are secreting in culture. You probably, it's an inefficient way in terms of the use of number of exosomes. So we can now get exosome products like 15 billion exosomes per cc. When we started doing it, it was like 500,000 exosomes per cc. Like 15 billion exosomes per cc, like that's a ton of exosomes.
Yeah.
Now you might only need 20 or 30%, like 30% of those, like we don't know, like how many of those are actually applicable
right.
for the specific injury that you have.
So are these
And so,
are these like if I banked my stem cells, can you just get exosomes from that?
so not yet,
Okay.
but
That's
maybe
coming.
soon.
All right. And maybe soon as in I wouldn't need to bank a second time? Like
No, well,
figure-
because your cells in culture
yeah.
are releasing exosomes. What would need to happen is they would need to set up a facility that could take that culture media and then process that for your exosomes and then save your exosomes. Now, the difficult part with that is exosomes have a shelf life. They last for a couple of years at like negative 80 degrees. At negative 20, they last about 6 months. They start degrading because they're proteins, they're microRNA, so they have a shelf life. Okay. But theoretically, yes, you could harvest the exosomes from your stem cells that are already sitting in culture and use your own exosomes. It's just that the facility to do that hasn't been made yet.
So for now, the exosomes you get are from where?
They come from pre-COVID umbilical cord derived mesenchymal stem cell.
Pre-COVID? Why did you?
The reason why I said that was I didn't know that this was an issue for some people, but remember the COVID vaccine was a microRNA vaccine. And so there are people who have asked, they're like, are these cells, were these vaccinated cells?
Right.
And I didn't know. And so I had to call the guy who runs the company.
Got it.
And talk to their medical director. And they were like, no, like fortunately we've got a cell line that we've been using that's pre-COVID. And so, cause there is like exosomes contain microRNA.
Right. Interesting.
So someday we'll know which specific exosomes are better for like patellar tendon versus who knows what, lung injury versus cartilage versus disc. Do you see what I'm saying? That right now you get an aggregate of all the exosomes.
Right.
And like they work very well because it's like, how long does it take 10 million stem cells to create 15 billion exosomes? Nobody knows, like in vivo, like in your body, nobody knows, right? It could take a few days, it could take a few weeks, it could take a few years. Nobody has that answer.
Right.
But you could in one shot get 15 billion exosomes, put in an area of injury, and I'll tell you, they work very, very quickly.
Wow. What do those run?
They're expensive.
Can you give me an idea?
Yeah. So for an extremity injection, like for your knee, we do 15 billion. That'd be $5,000.
Okay. So you want to reserve that for something major.
Yeah. And that's another one where like, if you were going to do, so we have some people are like, well, I need 12 vials of exosomes.
Yeah.
Like, okay, then, we can figure you're not going to charge you, $5,000 for each. Like $5,000 involves the sterile prep, doing the procedure right, the image guidance, et cetera. But it's like, all right, I want to do 3 vials of exosomes. Then, okay, we can get closer to like, bring that price down.
And the banking, what does that usually run for general stem cells?
So we charge for like the whole harvesting process and then the initial, and that covers like the initial stem cell expansion at the cell bank.
Right.
We charge $7,000.
Okay. So $7,000 all in for the banking. We could theoretically have it forever.
Yep. And that doesn't cover like actual getting the cells from, so they charge you $500 per 10 million cells, which is like it's a screaming deal because
what is that price per cell?
well, yeah, I mean, but so to give you an example, like the allogenic products we were talking about, like the umbilical cord products, like you tend to get somewhere between 2 and 3 million cells per cc.
Okay.
And those cost in the thousands of dollars.
Yeah.
Right. So you get 10 million of your own for 500. It's a good deal.
Cool.
That said, that doesn't cover like we charge like
your own injections.
Yeah. And so,
IVs.
like the IV is $700, $750, like $1,500 for an extremity and $3,000 for spine.
Okay.
Depending on what, like if we're doing 6 levels of spine or 1 level of spine, but in general, we charge for just the sterile procedure. and then the cell bank, you pay them for your cells.
And how long does it take from banking to being able
ready.
to injection?
Usually 3 weeks.
Okay.
Is all with fat. Bone
Right.
marrow, because bone marrow culture is slower, there's less potency.
Right.
And so we don't recommend that anybody bank their bone marrow.
Yeah.
We like we've covered, we recommend fat.
Right.
They culture faster, so they're usually ready quicker.
Yeah. And so if someone is coming from out of state, which I'm sure you've worked with a lot,
Yeah.
they fly in for the banking and then they fly in again.
Well, it
for the
depends. So
injection.
we still do same day procedures where we harvest fat, we process the stem cells, and inject them all in one shot.
Oh, you can do that same day.
We still do that.
Oh,
yeah. And so we
got
didn't
it.
really cover that,
Okay.
but that's sort of like what before banking was an option.
Yeah.
That's all we had. So you
But
harvest
you can
the
do
fat.
both.
Yeah, we
Yeah,
do both.
yeah.
So as long as we can get enough tissue,
Right.
we can. So that's like when people are flying from abroad or
Yeah.
another state, that's typically what we'll do is we'll harvest, get enough tissue to bank, process and inject them with stem cells same day so that they can go home treated and then have ready and available for whenever next.
Makes sense. Awesome. Well, this has been a pleasure to have you on.
Thank you.
I want to close here shortly, and I just want to thank you for all your great work in the world and
Appreciate
the
that, man.
genius you've shared with us today. And I've certainly learned quite a bit, and I'm excited to
Awesome.
take action personally on these stem cells. And in closing, what are some of the things you're committed to personally in your own lifestyle that you love to use to shake things up, stay young, stay active, stay healthy? What
Yeah.
are you working on now? What are you passionate about?
Yeah. Well, so I guess 2 things. What I'm passionate about is, so we're rolling out sort of a new sort of service, which is really it's a high end. So I guess one of the problems we run into in the clinic is, going piecemeal with these health things. You end up like running into problems in terms of like, man, am I really gonna get the MRI? Like, do I get the cardioangiogram? Like, let's just do the biomarkers and we'll do that later. Do you know what I mean? And
Right.
because it gets expensive,
Right.
right? Where we've come into a point where I'm like, we're not really doing. People come to us for the primo optimization, right? And then we go halfway because cost starts getting into the, and so this isn't something everybody's going to do, but we're rolling out like a high-end, all-inclusive executive, level
Bundled program.
basically
Yeah.
the executive healthcare team
Yep.
for longevity, which is you fly into Boulder for 3 days, you get the full body MRI, you get the coronary angiogram, you get all the lab tests, neurotransmitters, food sensitivities, genetic testing,
Stem cells.
stem cell harvest,
Yep.
deployment if you want. Depending on the scenario, travel at medical assistant included,
Yeah.
PT, personal trainer included, the whole bit. So it's an expensive program.
Yeah.
But I'm excited because the plan is we want to democratize it. Like, we want this to be available to everybody.
Yeah.
And the problem is when you put it at a price point that everybody can afford, you can't actually do all the stuff. Is this making sense? And so starting at the high end, creating, which will enable us to scale, because this is the problem anyway. So what I'm passionate about is how do we expand this, right? Like there are a lot of clinics out there, including like HealthSpan, so Tony Robbins, fantastic book.
Yep.
Like, we get referrals from their clinic because they don't do stem cells. They don't have providers who know how to do this stuff.
Oh.
They understand the fun.
Right?
But this is my point. This is where I'm shocked. I'm like, what? I view them, not that I consider myself a competitor to Tony Robbins, but I'm like they're a competitor, right? Like, they're like, why are they referring us patients?
Mm-hmm.
But it's like, there aren't providers who know how to do this stuff.
Yeah.
Right. And so how do you scale that? So you have to grow the provider end. and anyway, so we're rolling out so I'm psyched about sort of our next step in the clinic, which is rolling out a high-end executive team for your health.
Love it.
Which will then help us be able to hopefully make things more affordable so that it can be done on more people.
Right. Like you said, democratizing.
Yeah.
Yeah.
So that's what I'm passionate about right now. My own personal health. I mean, I do everything we just talked about.
Yeah.
I just finished a 4-day fast.
Nice. Call me next time you're doing it. I'll hop on and do it with you.
Okay. Yeah. I'll do that. I'll do another one soon because I'm behind. Peptides, we didn't talk about ozone.
Right.
I do ozone therapy regularly.
Yep.
It's an anti-aging treatment. It can be used as a directed therapeutic. And then we talked a little bit about how you can mimic autophagy medically. So these are methylene blue infusions, FOXO4-DRI infusions, rapamycin. So those are things that we haven't talked about that I personally do. And I guess that's probably, does that answer the question?
I love it, man. I haven't done the IV of methylene blue, but I had some today have you transcriptions? Have you heard of those guys?
Yeah.
So
you can get it orally.
Dr. Scott, I'm going to interview here shortly too about their products and their, they call them troches. Yeah. Well, thanks again, Dr. Voss.
Thanks for having me, man.
You bet, brother. Pleasure. I can't wait to see how everyone learns from this, implements, takes action, and possibly flies into Boulder to leverage the next level optimization strategies from this guy and his amazing practice.
Thank you, man.
Yeah.
Appreciate it.
Awesome.